Welcome to ERT's webinar, Airwave Oscillometry, Fast and Easy Assessment of Small Airway Function. We are excited to have you join us today. Before we get started, I wanted to share a few housekeeping tips to ensure your webinar experience is flawless. You are in a listen-only mode, so rest assured your identity is secure and you cannot be seen or heard. That doesn't mean you can't communicate with us. Your control panel is on the bottom of your screen. The center button, and perhaps most important, is the Q&A icon where you can enter questions for the presenters at any time during the webinar. As well, please use the chat if you are experiencing any technical difficulties. If we do not get to your question during the webinar, we will follow up with you separately, so please do not hesitate on holding back any of your questions. And finally, we recommend you close all your windows except for this browser for the best audio and video experience. So let's get started. Phil, I'll turn it over to you.
Yes, hello, welcome everyone. I wanted to welcome you to today's webinar from ERT and Thoracis, which is really focusing on the fast and easy assessment of small airway function using Airway's oscillometry. So with me today is Dr. Leonard Lombard from Thoracis. So he is the clinical director for Thoracis Systems. He's also an adjunct professor at the Meek and Christie Laboratories in the University of McGill in Canada. So both of us have really been involved in respiratory drug development and respiratory testing for more than 20 years. And I think we've had very much a convergent path here. Both really been suffering from how to understand what the drug is really doing in the lung and to show that in a clinical trial setting. And I think, we've gradually over time realized that Airway's oscillometry is really an underutilized tool in really trying to bolster that understanding. So, welcome, Leonard. Hopefully we'll have a good discussion today.
Thank you, Phil. It's a pleasure to be joining you here, and thanks very much for ERT to setting this up and joining forces with Thoracis today.
Excellent. Nice to be speaking with you. So moving on to the kind of the format. So what we've been doing is we've had a few webinars in the past and we've had a lot of interest from different parties. So we haven't always been able to actually address all of the questions that have been sent in. And then subsequent to the previous webinars, we've had more questions sent to us. So what we thought we'd do is try and collate some of these questions and then have a brief discussion between Len and myself to look at the potential of oscillometry and to try and answer the questions in the round. So if we want to move on to the first core question, really. So this is really around about the difference between oscillometry and force spirometry. So the question really is Airway's oscillometry avoids much of the technique-based variability that we see with force spirometry, but are there patients where the technique isn't quite appropriate? So I really wanted to just kind of highlight with you what we think the core advantages are, and are there any patients that really, we still have problems with when we're switching into oscillometry?
I think this is an interesting question, and it's one that I also have received a number of times going to conferences and such. First, let me say that all techniques have limitations, and I think it behooves us as scientists and researchers to understand what the limitations are with each and every technique we're using, so we don't use a technique outside of its possible scope. That could lead us totally wrong. So spirometry has some obvious limitations in a number of patients, that's well known. And that can be due to physical limitations, for example, muscle weaknesses. They might have had recent surgery that prevents them from doing forced exhalations. They might have other physical impairments, and also some mental impairments that could make it difficult for them to understand how to do this. They might have craniofacial abnormalities that makes it hard for them to handle the device and such. But then you have children. Children, they really have a hard time understanding how to do this. And the same goes for elderly people. So there are a number of issues with spirometry. That being said, when it works fine. So it's not that we need to throw it out the door. We just need to make sure that we understand its limitations. Oscillometry Of course, if people absolutely don't understand how to do it, they couldn't do it, right? But it certainly carries very much fewer issues than spirometry when it comes to patient dependence, because there's very little of that with oscillometry. And it doesn't carry any warning labels for contraindication, for example. No efforts are really at all required on the patient's part. Indeed, they just need to breathe quietly into the device. It can be done in pretty much any position. You can be sitting or lying down, you can be reclined. However, it's also important to remember that exactly the same way as spirometry depends on the patient's posture, the same applies to oscillometry, because your body will actually adapt to the situation, the posture you have. So if you're lying down, you will have one lung mechanic. If you're sitting up, you have another. So if you want to compare them, you have to make sure that the patient is always postured in the same way. But that goes without saying for any intervention you're doing, essentially. Yeah. So I think, at the end of the day, this is an easy to use technique. It demands very little effort on the patient's part. And the fact that it's so quick and easy and very repeatable makes it really ideal for large drug studies, because you can do it repeatedly with different operators and still rely on the quality of the outcome. So I think that's really what makes it very useful for drug studies.
Yeah, I mean, you've raised some really, really interesting points there, because we see the same thing in clinical research. I mean, if you start moving into younger age groups and the pediatrics, the level of variability we see is really quite extreme. I mean, it's in a standard adult asthma population, we may see a kind of 15% variability in the lung function over time, but this goes up to, way above 35, 40% in some pediatrics. So just and a lot of that is based on technique. And again, I think you made a nice point about how easy it was just breathing in and out. I mean, of course, for spirometry, you're actually physically changing the lung for the whole nature of depending on how forced the effort is. So, and again, that just opens up the variability based on technique. So if you generate a really forced effort, particularly in things like COPD, you get complete pressure dependent airways collapse and a narrowing of the airways and a very slow emptying. But if you have a suboptimal effort, the airways can maintain their integrity a little bit more, and you get more air out, kind of paradoxically. You don't blow as hard, but you get a higher figure. So it just creates variability, which is really the enemy of drug development.
Yeah, no, I think it's very hard to fool spirometry, because you can't fake being better than you are.
Yeah.
I think if you really put your tongue into the device, yes, you could look worse than you are. But that's something that we most of the time catch when people do things like that, and that's not normally the case. So no, I think being able to have something that's reproducible, that is not dependent on the patient's own effort, is very important. I like to say, when I do more academic presentations and discuss the differences, is that when you do spirometry, you asking the patient to provide the test signal for you. Mm-hmm. How awkward isn't that? Whereas with oscillometry, we are providing the test signal. So we are on top of what kind of probing we are doing down the lung. Yeah. And that's a fundamental difference.
Yeah, and I guess that test signal is standardized. I mean, you have a consistent signal, whereas if you're relying on technique, that's where some of the variability comes from. So yeah, that makes sense.
Yeah, but on the other hand, these two techniques, they do measure the same body system of the lung in this case. Mm-hmm. But they're measuring different aspects of it. So we don't need necessarily to exclude the one or the other. It all comes down to, what is the question you want to know? If you want to know how quickly people can exhale a certain volume of air, well, oscillometry is not the answer. No. Then you do spirometry. If you want to know how the small airways are doing, if they're homogeneously or if they're heterogeneous, if you have a more peripheral or more central issue going on in the lung, then you use oscillometry. Mm-hmm. So, I have different questions.
Yeah, and again, I mean, we seem to be transfixed with FEV1 in the kind of regulatory field for new drugs, and of course, that's it's not a very sensitive tool for picking up changes in the small airways, for example.
No, it's not. That's so true. Yes.
Yeah. Okay, well, thanks for that. I mean, let's move on to the next question. It's really around interpretation of oscillometry. So AOS, appears to be much more sensitive at picking up changes in the lung, but historically, this sensitivity was considered to be difficult to interpret or difficult to manage. What's your thoughts about that? I mean, is there a kind of area where we can kind of set out a minimum clinically important difference, or what do you think? How do we interpret the data?
No, I mean this is always a moving target, and I think if you go back to the old literature for spirometry, when that started first picking up in the late 50s and in the 60s, they had very much the same discussion. How do we understand this? And then there was some sort of consensus eventually evolving around this. And now, I mean, I see colleagues who just throw an eye on a spirogram and they can read tons of things out of that, just the shape of the curve. It's really pattern recognition. The same applies to oscillometry, of course. If somebody experienced looking at an oscillogram, they can read very much out of that by just quickly looking at it. And then you can, of course, extract a lot of parameters that would sort of underpin and quantify exactly how things are going or how things were done. So we know quite a lot about how to interpret oscillometry, and much thanks to the modeling work done in preclinical lung models of human diseases. And I've been involved in some of that myself. But also recent work studying advanced lung imaging in humans has essentially confirmed what we have previously found in mice and rats. So there's a strong correlation between lung volume, obstruction, lung derecruitment, and changes in reactance parameters, for example. And analogously, for the resistance side, there's very strong correlation between heterogeneous airway sort of constrictions going on in the small airways and resistance parameters. So all of this has been sort of worked out, and I doubt it will change much in the future. I think the groundwork has been pretty thoroughly done. And if you go back and look at the very first iterations of oscillometry, for example, the ones that was sold by us a few years ago, there was a long list of parameters being shown to the user. And I understand that was really confusing, because if you don't have the scientific background, you wouldn't know which one to look at. So that has now been honed down to essentially a couple of, or 3 or 4 parameters, something like that people look at. And I think that makes life a lot easier in order to understand what is going on. So we're essentially looking at frequency dependence, which is an indicator of heterogeneous or homogeneous ventilation in the lung. And we look at the reactance, area in the reactance curve firsthand, and that gives you a very good measure of the obstruction of the lung, and very closely related to the volume of the lung that is available to be oscillated, if you like. So when it comes to the question about minimally clinical relevant changes or parameters, I think that is very disease specific. Because in some disease you have really high resistance, and in other diseases you have very large changes in reactance. So first of all, you need to understand, what disease am I looking at? What kind of indication are we looking at here? So it would be futile to look at change in resistance if the disease doesn't carry a lot of resistance changes, for example. So that's the first thing.
The one thing I was just thinking of here is that, I mean, in the kind of whole drug development setting, I mean, I've seen historically that, Airway's oscillometry papers are really good at helping to understand how the drug is working. I mean, if you look at ultrafine particles for steroids, for instance, you can really start to see how they're impacting the smaller lung more effectively. But when it comes to larger programs, I mean, how does the endpoints correlate with other kind of drivers of benefit? I mean, can you correlate it well with imaging, or correlate it well with quality of life improvements, or I mean, and I think we're going to talk about some different indications as we go through the questions. But what's your kind of top line thoughts on that?
Yeah, that's a very interesting question. I mean, several years ago, I did a study in mice where we were able to really strongly correlate CT imaging and lung volumes detected by CT and correlating that to essentially reactance parameters. And now recently, just a couple of years ago, there was a group in London, Ontario, under Grace Paraga. They actually established a very nice similar correlation between MRI and oscillometry measured with a tremor flow. Again, very nice correlation between reactance changes, area and the reactance curve, AX, and the MRI imagery, where you can see that lungs are either well filled in a open lung, healthy lung, or a treated lung, supposedly. Or you look at somebody with asthma or COPD, and you will see patchiness where the lungs are less well filled. And it correlates very, very well with the parameters that we extract from the oscillometry. So I think that is sort of nailing it down. But as always, you need to identify the group of patients you're going to study so they're well characterized, so they actually have the things that you want to treat. So, I mean, if you just ask people, do we have a doctor's indication or diagnosis of COPD, and they say yes, but COPD could be a lot of things. But if they don't have peripheral airway closure, they might only have some bad bronchitis, sort of COPD. They may not respond the same way, right? And all of a sudden you have a huge variability in your material.
Yeah. No, it's interesting. I mean, it's kind of sort of the next question is really kind of related to some of this in terms of, what endpoints do you think we'll be able to use to drive a label claim for new medicine? So again, I mean, at the moment, I think where we stand, and correct me if you have a different perception, but oscillometry seems to be really good at helping you understand what the drug is doing. So, and to be able to show a kind of, proof of concept, it's very good in that respect. It may well, help you to show, differences in smaller patient populations in different doses. But when it comes to a kind of label claim for, maintenance therapy or something like that, it's a little bit more tricky, because I think historically, we've always used either exacerbations, a symptoms-based endpoint, quality of life-based endpoint, and then in addition, a kind of broad FEV1 spirometry-based lung function measure. Can you ever see us having an impulse oscillometry measure instead of that lung function, or do you think it's going to be a composite? What's your thinking there?
I don't think I don't think that there will ever be, or it should be, a single parameter on which we should focus for claims, unless you have a very digital, on or off disease. Bone is broken, yes or no. That's a simple one. Most of the diseases we look at, in lung diseases in particular, are very complex and will manifest in several different ways. And even if you're an asthmatic, you might have different shapes and forms of your asthma compared with your neighbor, right? So I think this will ultimately come down to what the question is you're trying to address. To look at larger airways for drug effect will be futile if you know that the disease is located in the small airways, right? So you're just barking up the wrong tree. As is currently the case using spirometry, because we know that it's primarily dependent on large airways, and only if the lung is really severely affected will spirometry be affected. And I think we might talk about some aspects of that later. But maybe some good drugs were just lost because the assessment was bad, using the wrong techniques. I mean, that's quite possible. So that being said, I think oscillometry has a huge advantage over spirometry in that we know that, at least broadly, if the effect is in the small airways or more centrally, we can separate those things, right?
Yeah, no, exactly. And I've seen some pretty good examples in the past where, we've been involved in developing, anti-inflammatory drugs in COPD, for example, and the initial phase 2 data was just completely elevated. I mean, it was inappropriate, completely elevated compared to what the phase 3 data turned out to be. And of course, then you go through a whole phase 3 program, and at the end of it, you don't have a drug that's approvable. So I think this is where oscillometry really kind of comes into its fore. Is in terms of giving you much more confidence that what you're looking at is real, and that there really is a drug worth developing for small airways and improvements. So
Yeah, but yeah, I agree with you. I mean, but coming back to your first question, what endpoints could we use? Come back to my earlier discussion point here, that we now hone down to maybe just very few parameters. And I think frequency dependence, R5 minus 20 in our case, and area under reactance curve capturing the reactance changes, those are definitely the two strongest candidates to be used. But hey, not all research has been done, so who knows what will come in the future. But for the time being, I think that is it. But I would like to raise another, what I think is a very interesting point, because when I worked with Big Pharma myself several years ago, and it was almost always the case that, okay, you got the patient in, you tested them with whatever, you gave them the drug, and then they came back and you saw if the drug had any effect. There might have been, maybe a couple of intermediary measurements, but it was really, before and after treatment. That's was the protocol. But and of course, if you have a very complex measurement you're going to do, I mean, that could be EKG or ECG or spirometry too, because it's depends on coaching or somebody else being able to read and help you with the measurement. That is difficult. But with oscillometry, we have this advantage that it's so easy to do. We can even let people do it at home. And there are actually a couple of publications where that has been done. So if you then start looking day by day on what these parameters are doing, you're going to find, interestingly enough, and there was a publication just a year or two ago from Australia in children with asthma, and you could see that on a given day, the kid could be doing just fine. The next day, they were doing horribly. And then a few days later, they were doing fine again. But over time, what we could see is that the parameter was sort of trending away from what would have been a normal stable baseline. So just by accident, you could have somebody who's doing pretty badly, but on that particular day coming in, they're doing fine. And that doesn't spirometry or oscillometry. It's just the variability of the disease is doing this. And variability is, I think, an underestimated or poorly understood component of a disease. So I would like to advocate for more frequent measurements, doing a trend analysis and see where things are heading, rather than maybe looking for a test one day randomly.
Yeah, and again, that fits into kind of the modern day kind of desire to have more, remote-based trials. So less dependence on coming into clinics and the ramifications of that. But you raise a good point there. I mean, it's almost, I think what you're saying is that you're getting more variable data, and it's that variability that's driving the gradual loss of control. So heading towards an exacerbation or just poor asthma control. So maybe it's the variability of the endpoint that we need to look at in terms rather a kind of a stable measure consistently versus a more variable measure.
I think that's a good point because people are normally not horribly bad or totally perfect, right? And I mean, and that goes for almost all kinds of ailments. That one day you're feeling okay, the next day, no, I'm feeling bad again. Just look at the recent COVID-19, where people have this post-COVID syndromes. Some days they're feeling fine, then all of a sudden they have a fever day, and then the following day they're fine again. And I think that is just the way our bodies are working. It's trying to adapt and adjust and fix things that are not quite right. And this is what is reflected in the physiology when we start measuring it. But I think if we were to look at more frequent and do trend analysis, we would find two things. One would be that the trend might actually be data. And that would be an important piece of information. The second would be that we would not be trapped in false really bad or false really good days. And I think we would actually save time and numbers of patients we need to include in our studies, because the variability. I would say, I actually add a fourth thing: variability in itself is data.
Yes. No. Agreed. Yeah.
Which is apparently and it doesn't have an endpoint that we haven't even discussed. Nobody has really discussed.
No, indeed. I mean, I think it's a good point. I mean, the other thing that comes to mind, we talk about variability within a test. I mean, it's actually, using this in a kind of composite way to look at the relative change between things like force spirometry and oscillometry. So you would expect that, I mean, there is a little bit of variability, but you may well be able to see a consistency in effect. So, I mean, if it's a true disease variability and not a technique-based variability, you'd expect both parameters potentially to change. So it may well be that you could use oscillometry to help, identify implausible, spirometry measurements, which are based on technique. So, I mean, it opens up a whole range of possibilities.
It's actually a possibility. I think it would have to be studied, but yeah, I agree. There's a potential.
I mean, we're working with a number of sponsors at the moment with, both spirometry and oscillometry in larger scale studies. So I think it definitely opens up the potential to look at the data and see what comes out. So
yeah, that's fantastic. Yeah. But I think just to summarize this little thing here, tracking, over time would reduce the risk of relying on a single measurement occasion, right?
Yeah.
It would provide a trend over time of the lung function. And I think that's very important. And of course, telemedicine will open up this possibility for wider use. And I think we're sort of well positioned to do this.
Okay, excellent. So let me move on to the next question. So again, I mean, this is another one where I've had quite a few people talk to me about this. So within drug development, there's often a potential that drugs will damage the lung. So, I mean, anything that's inhaled, you generally have to check to make sure it's not having no negative impact. But there's a whole range of drug mechanisms which can drive kind of interstitial lung diseases and fibrotic changes. So it would seem that, oscillometry, because of its sensitivity to pick up, small changes earlier on, this might be a useful approach to try and look for, damage to the lung. Any thoughts on that?
I find this a very interesting sort of thought and something I've been actually involved in recently. But let me spin back just a little because it's well known that certain cytostatic drugs, bleomycin comes to mind, can induce fibrotic lesions in the lung. And that's something that's being used in mice and just as an inducer of fibrosis, and then to test drugs preclinically. But it's also true in humans. So I think that's an example where the safety of a drug could actually be tested, or patients under treatment could be monitored on a regular basis to see if there's something happening that would implicate that a change of treatment or so would be necessary. But essentially, any drug you give somebody, you could use oscillometry to see if anything's happening. I mean, honestly, I don't think there's been a lot of studies aiming at that in humans, but certainly in animals, there's a lot of precedence for this to be something that really should work. And a lung is a lung is a lung. So if mice respond, we are very likely to respond too.
Well, the thing that comes to mind when I look at these studies when you're using force spirometry is that, I mean, a lot of sponsors will just ask a local lab to do the core work, and what we've seen historically is that about 10% of the data that's sent to us from labs, even after you train them, fail to meet minimum standards. So the danger is, of course, is that you'll get variability in technique, which will either generate an artificial signal for sudden increase or decrease, or you can potentially modify your baseline and then hide damage to the lung. So, I mean, this is, either you don't want. So, I mean, it would appear that oscillometry would be much less prone to that.
Well, and this raises another interesting aspect of doing physiology where it depends on the patient, because now we're talking about patients who are treated for not lung diseases. So these patients are not used to do lung physiology. They're not used to be in a spirometer suite, sitting body boxes, blowing into spirometers and whatnot. So they might be even more prone to make errors, if you like.
Yeah.
So for them, it's probably even easier and even much better to do oscillometry, because they would not have to do any performance. And if you have a career asthmatic coming in at age 45, I mean, they've been through hundreds of spirometers.
Yeah.
Whereas somebody who is receiving a cancer drug at age 45 and never had any other disease wouldn't know anything about it. So yes, you will have this sort of training aspect coming into play too.
Yeah.
There are a couple of other examples that are sort of tangentially at least related to what you're talking about here. And one thing that comes to mind that was recently published is a study in lung transplant patients. And they, I mean, sort of contrived maybe, but they got the treatment with a new lung, right?
Yeah.
And that lung is hopefully working fine when it got inserted into the patient or the recipient. And we know that they frequently suffer from rejection, and they need to have their drug regimen changed and whatnot to cope. So, and just to confirm what is going on, you need to do a bronchoscopy. You could do things like CTs and stuff like that, but that's exposing them to risks. Bronchoscopies are not innocent procedures either. There's a high risk for injury, pneumothoraces and stuff like that. But there was a recent paper that demonstrated that oscillometry can give a really early warning of acute rejection up to 14 days before any other signs show up. We're talking about all kind of signs, including patient's own perception, spirometry, what have you.
Yeah.
And so monitoring with oscillometry will likely improve the detection rate and could potentially save lives here, or at least extend the life of the transplant.
Yeah, no, exactly. I mean, it's
on the patient, on the society, on everything. And there are actually companies who are looking at drug effects on rejection, and I know they're interested in oscillometry. So I think this is sort of an example where non-pulmonary drugs, because these are treatments of the immune system going on. So just another example of where this can be.
I mean, I think you're completely right. I mean, you've got the other problem, of course, is that spirometry is contraindicated immediately after major thoracic surgery. Yes. So you're not supposed to be doing it. But then thinking about it from the patient perspective, if you've got a new lung, you're not really going to want to start doing a forced spirometry maneuver. You're going to be pretty nervous, and as a consequence, you're going to gain confidence over time. So your values are going to change. So you've got all these confounding factors. And again, it's the same, like you say, for a patient into a trial that's not used to spirometry, they're going to have a learning effect, which will gradually improve their lung function. And of course, that's going to be masking any effect of negative effects from a drug damage. So.
No, but you've got two things varying at the same time, and they might cancel each other out. So it's hard to know what's really happening there.
Yeah.
I mean, spirometry is being used, home used with lung transplant patients, and they do catch people who are rejecting. It's just that oscillometry will make that detection 2 weeks earlier.
Yeah,
and that's a lot of time in the life of a lung transplant. Because if you can change the treatment there and then, you can dampen it, and of course, we all suspect that will also extend the life of the transplant and the patient.
No, exactly.
So,
very interesting point. So, I mean, along the same lines, really. I mean, just thinking about other potential uses of oscillometry is really kind of neurodegenerative diseases. So, again, I mean, we started measuring. Lung function is a good biomarker for disease progression. So, we look at things like ALS or Duchenne, and you can see an onward decline in lung function. So, but again, you have the same technique problems. I mean, it's difficult for the patients to do this. Effectively, you have the difficulties with the seal around the mouth. Any thoughts on oscillometry in that instance? I mean, again, I would think it would be a good candidate to show benefit.
It is actually, and there is actually a publication that was in Chest already in 1991 by Wesseling, and they show that the spirometry quality changed with effort. So, and it's a very nice curve. So you can just look at that, and that's your proof in the pie. How bad it can be. And they also looked at neurodegenerative diseases. So yes, it is definitely something that is very complicated. By the nature of neurological condition, can affect the ability of performing, as you said. Or they might not be able to sit in a plethysmograph, or they may not be able to position themselves very well. So I think as long as you can keep a good seal around the mouthpiece, you should be able to achieve a good measurement. Of course, somebody else might have to support your cheeks, but that's fine. Indeed, I have a friend with such a condition, and he's now wheelchair bound, but I've successfully measured his lung function with a tremor flow. He happened to come by at a conference a couple of years ago. He's a doctor himself. Yeah, no, and he said, "Can I do this?" Yeah, can you keep your lip around the mouthpiece? Yeah, sure. It worked.
Yeah, no, that makes sense.
There are actually a couple of publications out there. There was an abstract at ERS last year where they looked at a group of patients with oscillometry, and about 40 or so of them, they had an abnormal oscillometry, and this was attributed to restrictive and obstructive impairments. But then there was also a group of 30 or so patients that were perfectly normal.
Yeah.
And so they were actually able to identify people with neurological disease, and that was not the only thing they had. They had other things going on as well. So yes, I think the big advance with oscillometry is that it will be independent of the disease progression. And insofar that the neurodegenerative disease impairs your ability to clear your lungs or keep them open, that will show up because the technique is agnostic to what caused the obstruction, right? So I think we will still be able to pick it up. So it should be possible to track the development over time, in particular if the measurements are done on a regular basis, so we can follow the trend. Again, we know that unfortunately a lot of these diseases, they have a decline in function generally, and so being able to follow the trend here might be very important.
That's the core benefit. I mean, what have we been doing in lung function is really trying to reduce that decline. So and it does correlate very well with other outcome measures. So it seems like it would be a helpful addition.
Yeah, I think so, and honestly, I think it's the only way I know of today where you could do a measurement on a person who is more or less paraplegic, right?
Yeah. Oh, that's very helpful. So there's another question that came in. I mean, we're talking about technique, etc. And one of the problems we see consistently with spirometry, particularly if you're moving into new or novice sites, and particularly in these days with COVID limitations where you can't go and do face-to-face training very easily. So this question is really pertinent to all of that. It's, I mean, how easy is it to train someone to actually generate reliable data? Because again, I mean, this is, with the variability in spirometry, sometimes people get it, sometimes people just don't. And so what's your experience from the oscillometry side?
Yeah, they get it or they forget it. Yes. No, I think this is one of the beauties with oscillometry. It's very easy to learn somebody to do it. And it's something that we regularly do at investigators meetings. We've done it together with ERT. We've done it with academic, bigger studies. Either we go there in person and have the training on site. But we've done a lot of those online, particularly last year, and we can monitor the performance via video link, similar to what we're doing now.
Yeah.
And we can go over the data after the test has been done. We can link up to the computer they're using to do the test. We can go over with them exactly how things were done. We can help them do quality checks. We can show them how to export and take care of data. So all of that is definitely doable online. It's of course always better to be in person, but
I mean, our experience, I think, is that you can train people relatively easily. So it's but it's nice to hear you have the same impression, really.
We do, and I did one yesterday, just as an example, and usually we have a two-piece thing. Typically I give a somewhat of a background talk, a very superficial but still scientific presentation what oscillometry is about, explaining how to interpret data, doing the quality checks, and then one of us or two of us together do the actual demonstration of how to do it. Hopefully, if people have their own thermal flow on site, we wanted to do it themselves while we observe them. I think the basic stuff, I could probably train somebody to just do the maneuvers in less than 15 minutes, honestly. It's not very, very difficult. Okay,
that's it's definitely good to hear.
And we also integrate with, now I'm talking with ERT here, we are integrating with your master screen software. So this means that if somebody does a clinical study together with you and using oscillometry, they will have their workflow, lined out for them. And there's really very few things that could go wrong in that process.
Yeah, I know. It's really set up to guide them through it. To avoid
you can't really screw it up. And then we will always be available for customer support and additional training if need be.
Yeah.
So, yeah.
Yeah, no, I mean, that's
an easy question.
I mean, one of the benefits of the MasterScope system is that we can actually program the operating system in local language. So, if you're running studies in Japan or China, the operators can actually see the instructions in their own language, which is really really ideal. So,
yeah, that's good.
Okay, so let's move on to the next question. So again, interstitial lung disease. So we've talked about safety, we've talked about neurological disorders, but again, I mean, we see a lot of work being conducted in interstitial lung disease. So what would you use in that environment? Based on oscillometry, do you think there's scope there?
For interstitial disease, yes, it is an interesting group of diseases because IPF-ILD have been studied with oscillometry, and while not extensively as asthma and COPD because they're just more common diseases, right? But nonetheless, the principles are the same, and it turns out that most of the things we see there are due to the stiffening of the lung tissue, of course. So this means that if you look at the oscillogram from a patient with IPF-ILD or some other interstitial disease, typically you see that resistance is relatively spared. They can have a perfectly normal resistance, actually, in the cases I've seen, whereas the reactance part drops down. And it seldom go down as dramatically as with COPD and asthma, because they have much more profound airway closure, but the stiffness will definitely drop the reactance part. And now you can see that because you don't have a change in resistance, but a bigger change in reactance, that sort of gives away what the whole thing is about.
Yeah.
You would never see somebody with asthma or COPD not having a change in resistance.
Yeah. I mean, one of the problems we see with interstitial lung disease and IPF, it's really is often a learning effect. So it's quite normal to see maybe 30 or even 40% of the patients showing an initial improvement in lung function, and then eventually, you start to see the inevitable decline. So,
Yeah.
and a disease where it's just characterized by kind of relentless decline in lung function. I mean, I'm always worried that technically, particularly with short-term studies, is that you're really underestimating the impact of the drugs because of the effect. So this is one of the reasons why I was thinking that oscillometry might be might give you a more stable baseline to look at subsequent change from. So
I think the issue you're mentioning with spirometry improving with training is less of an issue, maybe, or it's not an issue with oscillometry because you can't train it, right?
Yeah, exactly.
Again, the people who suffer from interstitial disease, they're usually not career, patients, because this is something that comes often later in life. So they never been through the PFT lab as frequently as the asthmatics who started as kids, right?
Yeah.
So when they find out how to do this, yes, they probably very likely will improve.
Yeah.
This one is independent of the patient. The other one is almost 100% dependent on the patient, as we said in the early questions here. And I think this really comes back to the first principle of doing biological and clinical research. You control what you can't control.
Yeah.
This biological variance, and that's what we're interested in. That is our signal or outcome.
Yeah.
So
no,
either you have to train your patients until you know that they're performing at the top performance level and trust that they continue to do so despite getting sicker and sicker, or you can do something that is more or less independent of what the patient is doing.
Yeah. No, that makes perfect sense. I mean, so I mean, it just brings us to kind of the end of our kind of prior question list. But I just wanted to kind of try and summarize all of this in terms of where we feel we are and what we think we could offer to people moving forward. So, I mean, from my side, I mean, it's pretty clear that we've got a pretty good understanding of what spirometry can do for us, and the regulators know it and accept the endpoints. But I can see that in spirometry there's still areas for us to improve because of this controlling variability and controlling technique. But this is where I see oscillometry is really coming in these more problem patient populations, such as pediatrics or elderly or some of the other populations that are finding it difficult to maintain the technique. I really think that oscillometry is something worth considering. So it's just whether we can find, and I think that the next few years are really going to be helpful because I think we're starting to use oscillometry in bigger trials with lung function at the same time, and I think it gives us the opportunity to see whether we can generate composite endpoints or whether we can really try and crystallize the exact improvements that regulators might consider as being acceptable for a label claim. I mean, is that broadly how you see it, or?
I think I agree with you by and large. We all know that regulatory bodies are slow to move. I think they should be slow to move because it's all about patient safety and feeling comfortable that the decision you are making are based on solid scientific ground and not sort of just jumping around, with a sort of flavor of the day. So that's understandable, and I think it should be that way. That being said, I hope they are also amenable to accept that some of the older techniques may not reveal the whole truth.
Yeah.
And if you see it that way, I think it would be much easier to make oscillometry acceptable because it's actually another way of investigating how the respiratory system is doing.
Yeah.
And I mean, I said already from the beginning, we don't want to throw out spirometry. Spirometry has a lot to go for it.
Yeah.
But we also need to understand its limitations. So, I mean, you can use something here that is patient independent, quick, and it has excellent reproducibility with, no training effects, apparently. It's easy to use, easy to understand, which means you have a high quality output, which you can rely on, right? And we mentioned this, that correlates with patient reported outcomes. And it actually does better than spirometry, and spirometry is not really that great. it has well-defined outcome parameters with known physiological correlates. And that, in my mind, should make it suitable for claims. Because if the whole trick with doing physiological measurements is that we get a change in some parameter. And yeah, you can always measure. But what does it mean? You need to correlate it with something that is real. And that is, the link between structure and function. So if I see a change on an oscillogram, I know with some certainty that this is probably the pathological change that took place in the patient, or the change induced by the treatment. And then we have, the things we already touched upon. You can do it in home monitoring settings. You can get more data points. And the functional impairments we touched upon here at the end.
I think you mentioned something earlier about having a specific research question. So I think from my side, I'm sure it's the same for you. I mean, for the people watching this, if they have a specific idea of what they want to show with their drug, I think we can sit down and really show them how a combination of spirometry and oscillometry can really help tease out what they want to do. So because if you understand, particularly in today's environment with personalized medications, if you understand what the drug is doing in your patients, you can work out who the responder patients are, what the drug effect is, and how to design your phase 3 to optimize your results. So, and that's always going to be better in terms of getting it approved. So.
Yes, I mean, when we talk about drug research, we often think about showing that the drug is working, and then everybody's happy. But there's a long life and more important life, maybe after you decide that, this is something we want to continue with. It's not only drug candidate, it's actually a product, right? So going into late phase 3 and then phase 4, it's going to be even better, I think, to use a technique that's easier to use, because you can broaden it and you can actually connect with the doctors out on the field. Because if they use the same technique you used when you documented the drug, I think that's going to increase the understanding for what the drug is doing, but also how the patient is doing.
Yeah, and their ability to manage the patient long term. So
yeah.
Brilliant. Okay, well, thank you very much for that. It's been a great pleasure talking with you. It's I think we've got through the questions that we had pre-arranged, so we can open it up to additional questions from the audience at this time.
Yes, looking forward to meet you again, and thank you very much for having me.
Great.
Thank you, Phil and Lennart, for sharing your insights and addressing customer questions. And thank you to all of our attendees for joining with us today. In case you have not submitted questions in the platform, please share them with us at respiratory@ert.com. We welcome the opportunity to connect with you further. Thank you, have a great day, and please stay safe.